So I welcome each one of you who have joined online for this dilemma. Today I think we have a galaxy of experts here for discussion. So I welcome each one of you and request you to be delayed because there is a lot of discussions, expert opinions, lot of clinically relevant type of questions which we face every day in our busy OPDs. So let's start. It's basically we are going to discuss about this whole metabolic problems, especially patients with type 2 diabetes and how to deal with that. The focus is oral semaglutide today, but at the same time we will discuss about this adiposity and its risk associated with our patients and if we can help them in a better way than what we are doing up till now. So first I request Dr. Vedavati Purandare. She is a diabetologist and consultant at Chelaram Diabetes Specialty Hospital, and she is well known here, and I think she is very busy in her own conference, but thank you so much for coming here today. So Dr. Veda.
Thank you so much, Karina. It is pleasure and honor for me to be part of this meeting. Good evening, Dr. Sante. And as Dr. Kali Madam told that we will be talking about CKM syndrome, which is cardiovascular, kidney and metabolic. So as we see in diabetes also, there is a spectrum of dysglycemia, which starts from normoglycemia with normal glucose levels, pre-diabetes and the frank diabetes. So similarly, patients going into complications of diabetes like chronic kidney disease, diabetic kidney disease, cardiovascular disease, there is spectrum starting from no risk. We will see the CKM syndrome per se coined by AHA, where in stage 0, the person is absolutely fit, the weight is normal, the blood pressure is normal, the glucose levels are normal, lipids are normal. Then they go into a preclinical stage where they have risk factors for these CKM syndromes, and then the frank syndrome appears here. So what are the stages of CKM? As we discussed, that stage 0 is no risk factors, where the patients are following the 8 practices where they are having adequate sleep, healthy diet, regular exercise, the normal glucose levels, normal blood pressure, normal lipid levels. There is no smoking, which is a risk factor for CKM. So this is stage 0. Progressing to stage 1, where there is adiposity, where there is impaired glucose tolerance in pre-diabetes state. Then stage 2, where the dysfunction is in the form of diabetes, where frank hyperglycemia, hypertension is there, then metabolic syndrome is there, then early CKD, and then stage 3 and stage 4, where frank syndromes or subclinical CVD, ASCVD, subclinical heart failure occurs, and then in stage 4, where there is coronary heart disease, heart failure, atrial fibrillation, stroke, and peripheral arterial disease. So these are the stage 0 to stage 4 CKM syndromes, and basically as a clinician, we have to see that can I just make sure that patients from stage 0 don't progress to stage 1, patients in stage 1 to progress to further stages. What can we do? So what are the, if we get a, so we all will believe that lifestyle modification, that is healthy diet, regular exercise, stress reduction, tobacco, will definitely have a good evidence or will prove as the best remedy for CKM syndrome progression. But then if we have a single molecule or medicine which will act on cardiovascular, metabolic as well as the kidney disease per se, that would be really proving as a boon for mankind. So what are these GLP1 molecules? So we all know that initially the first anti-diabetic molecule which was discovered was insulin in 1921. So from 1921 to 2021, those 100 years were insulin era. Now we are into GLP1 era, where we are talking about a lot of GLP1 molecules. We have seen the injectable molecules. We are now using oral GLP1 molecules. Now we will be using dual GLP1 agonist. It will come soon in India. Then we will see the triple GLP1 agonist in the form of retatrutide, which will also have robust fat loss and benefit for CKM syndrome. So when we see the effect on CNS, there is beneficial effect, then there is beneficial effect for hepatic steatosis or MA, SLD also, then reduction in albumin secretion and decline in the GFR, BP reduction is there, anti-inflammatory effect is there, also it has beneficial effect on myocardium. So GLP-1 help as a whole in all the syndrome patients, and it has beneficial effect in all these systems, and there is robust data. The oral semaglutide, we have pioneer program, and injectable semaglutide we have sustain program, and we have seen that in pioneer 6, sustain 6 there is CVOT trials, and they have proven these molecules are basically, they improve the cardiovascular outcomes, and there is reduction in 3-point MACE, and also the nephroprotective action is proven. The cardiovascular superiority is proven by SOLT study, which is recently published, and the FLOW study showed that oral GLP1 also exerts beneficial nephroprotective action by direct effect on the kidney and indirect effect on the glomeruli. It also has anti-inflammatory benefits, and hence it is beneficial in CKM syndromes. And the current position, we all know the clinical guidelines as per ADA, EASD, AHA, the GLP1 agonist, they have come as priority, and where any patient with type 2 diabetes, if has more cardiovascular kidney risk, we have to think about GLP1RA, and GLP1RA have shown a very good CVD benefit. Also in patients who have weight loss as their goal, those who are obese, they are fat, the efficacy wise the fat loss is very high in semaglutide and tirzepatide, and also the glucose lowering effect is very good with GLP1RAs. Then when we think about metabolic dysfunction associated steatoliver disease, MASLD, there is data which shows that oral GLP1 as well as injectable GLP1, the dual GLP1 GLP1RA, they have beneficial effect in MASLD as well as MASH. And as per the European Society of Cardiology guidelines, they also recommend that whenever we see any patient with type 2 diabetes and with increased cardiovascular disease risk, we have to think about GLP1RAs in addition to SGLT2 inhibitors, because we all know that SGLT2 inhibitors also have organ protection benefit in addition to glucose control. So as per European Society of Cardiology recommendations, GLP1RAs with proven CV benefits are recommended in patients with diabetes and increased CVD risk. We know that liraglutide, the CVOT trial was leader, then lixisenatide was ELIXA, and the sustain and the pioneer program, they have given us confidence that GLP1RAs have good CVOT data, and hence we have to prescribe, or we have to think about prescribing GLP1RAs in patients who have increased CVD risk. And here oral GLP1 should also be considered in patients who are overweight and have increased risk of cardiovascular disease and chronic coronary syndromes. As per it is not just the heart but the KDIGO guidelines which are published for the nephrologist and for the physicians, we also prescribe GLP1RAs in patients who have increased risk of chronic kidney disease because of the direct and indirect effect. The beneficial effect of GLP1RAs is also seen in the initiation and progression of DKD. The flow data we will be discussing today, and that gives us confidence in prescription. So patients with MASLD and MASH also, the GLP1RAs and the oral as well as injectable, there is data, and this comorbidity of type 2 diabetes also we can handle with GLP1RAs. So in short, summarize, in CKM staging, the oral and injectable GLP1RAs, they definitely offer, in addition to glycemic control, a lot of organ protection in the form of cardiovascular and nephroprotection. They also have benefit in MASH, and there is evidence which supports utility of GLP1RAs in the spectrum. And all international guidelines, they recommend these molecules. So we all know that now in diabetes, we are moving from just glucose-centric approach to organ protection approach. So any molecule, when we prescribe, is it safe for glucose control, effective for glucose control, and is it offering additional organ protection? These factors come into mind. So with this, I just end my talk and I hand over the mic to Dr. Kai Madam.
Any questions which are from questions which are today?
Yeah, no, but we'll come on the stage. नहीं नहीं मला पण आहे सगळ्याच विचारलं चेअर्स
स्टेज वहाँ से बुक लेते हैं वो 2 चेयर स्टेज पे लेते हैं
2-3 खुर्च्या आहेत.
Can I meanwhile ask Veda one question?
Yes, please, sir.
On the effect on the eyes, there is
Yes.
concern regarding
Yes.
that
Yes.
non-arteritic ischemic optic
Yes, sir.
neuropathy
Yes,
and papillitis, etc., especially in diabetics. Because one surgeon, she was going to take, she had purchased the drugs also,
Yes,
but
sir.
reading this, she said ki this blindness will be very horrible, then maybe not losing weight.
So very
She was
clinically
non-diabetic.
relevant question, sir. So in patients who have progressive retinopathy or unstable retinopathy, the semaglutide or GLP1 analogs, we have to use with caution because it is seen that it might worsen. So in such patients, better to
साठी सर थांबणार.
use with caution, sir.
No, but then should all patients have a
Retinal test, sir.
no, ophthalmoscope
Before starting dialysis,
Sir, as it is
what is
we-
the normal, what would you do?
Yes,
Because
sir.
we don't do that. We are using a lot of this drug, but I have never asked the patients to do a retinal check before starting this drug. So what is the recommendation?
So as per the guideline screening of complications, the retinopathy we do once in a year. And for patients who have unstable retinopathy,
No,
it has
all
to
the
be.
diabetics, is the
Yes.
retina seen by all physicians? No.
For obese patients, we don't do.
No, what I'm
Just
saying
pure
is,
obese patient,
suppose this is the side
non-diabetic.
effect, so I'm just asking because I never looked at the retina before starting dialysis. So whether I should ask every patient
Ideally,
before we
sir.
start to
Yes.
check his eyes.
Yes.
Especially with longer duration of diabetes. And type 1 all. And if
So this
any
is, I
type
think,
2
an
person
important
plus
message
5 years, it's
that
very
before
important.
starting GLP, whether it's injectable or both, for both.
Yes, sir, absolutely.
You
For
should
any
look at the
GLP.
retina.
For
For any
weight loss,
GLP-1
obese
baseline
patients
retina
also
test
you
has
will
to be done.
recommend.
Yes, sir.
For obese patients also you will recommend retinal examination, non-diabetic.
Non-diabetic we will not do, sir, because it is the diabetic retinopathy part, which is unstable or progressive.
Even obese patients might get this NAION, neon, or they won't get.
So diabetic retinopathy part, the research has shown that if it is unstable retinopathy or it is advanced proliferative retinopathy, then it might worsen. And why is it so? Because it was linked with rapid glucose reduction.
Yeah.
As in pregnancy, we see that there is worsening of diabetic retinopathy. Similarly, with semaglutide, injectable or oral, the diabetic retinopathy part was shown to be worsening. Hence, better to check it, sir.
So in your clinical practice, have you seen worsening?
Not yet, sir.
Not yet.
It is like metformin, when we stop it below GFR 30, we have not seen lactic acidosis till date, but we stop metformin as soon as GFR goes below 30.
Incidence is very low, I think.
No, in your practice as a diabetic patient, no
Yes.
risk factors, no CVD, nothing. Does your prescription, at least will you advise GLP-1 as the first or second drug after metformin? What is the current guideline for diabetic patient without risk factor? First time you have detected,
Yes, it would.
should we start or should a physician start GLP-1 and please advise? Now the cost, we are not looking at the cost solution.
Yes.
Suppose cost is not the issue to a patient.
I will definitely prescribe, sir.
So what is your first drug now?
First drug is metformin, second is oral GLP-1 analog.
Oral GLP-1.
Yes, sir.
After
Because
retinal examination.
I will tell patient that in addition to glucose control, this will offer.
Fair enough.
Yes.
So in your practice, you will write metformin
Yes,
plus GLP-1 and
reverses.
then SGLT.
Yes, means patients who have increased risk of maybe urinary tract infection, postmenopausal ladies.
But GLP you are using as the first drug or second drug.
Second, add-on to metformin we are using for some
That
patients.
is ideal, but in practice doesn't happen. So like somebody is obese,
Actually, for
definitely
rebels,
GLP-1, but
for rebels it's more.
But otherwise, metformin, it's a patient with high cardiovascular risk, heart failure, he will be on SGLT2 inhibitor metformin or only on SGLT2 if we go by hierarchy.
Combining metformin with GLP-1 will increase acidity and nausea, maybe GI side effects.
Sir, in clinical practice, some patients they tolerate it so well that I really wonder because patients are started on 3 milligram of oral semaglutide. They say that you have given me for 1 month, but I don't have any problem. So should I escalate to 7 mg in just 1 week's time? And then 7 mg they also tolerate very well.
But some patients develop lot of GI.
Yes, there are few patients, and in such patients, then metformin and oral GLP-1 we may not
No,
prescribe.
what I'm saying is suppose suppose somebody comes on nausea.
Yes.
Now the half-life of the drug is 5 days.
Yes.
So should I stop the drug or tell them initially take twice a week, thrice a week, and then increase? Is there something like this? Or stop it? Suppose somebody is not tolerant, would you stop it?
So we give antacid and we tell them that you have some dry snacks after 30 minutes of oral semaglutide rather than having, means they can have some dry snack. There are mechanisms where fatty food we usually tell patients not to eat because fatty foods will increase the nausea part. So tell patients to reduce the fat in the diet, have some dry snacks, have more of fruits and vegetables which would reduce the nausea.
So when do you give this drug? Morning, evening, afternoon, late?
Early morning first tablet,
That we know. But after that you have a dry snack, no fatty food.
no fatty food.
But that decreases the nausea.
Yes, yes.
Usually we don't stop it. Like, we try all the measures, reduce
But
the
can you
dose,
reduce,
make it
can you
tolerated.
do it thrice a day, thrice a week? Alternate day, I'm
Yeah,
asking
we
you.
do that.
Some patients are doing
So
it.
that they tolerate
Yes.
afterwards.
They tolerate afterwards.
Yes. And we give means PPIs along with that.
Or
Before
give
dinner, we
ginger, etc. Yes.
So we move
And
forward.
sir,
Thank you.
as you said, now for every diabetic patient, whether should we go for adolescent, particularly for adults, is what they are saying. The caution is very clearly written. It is for patients who have received treatment for severe diabetic retinopathy or have undergone laser treatment. You have to be cautious. So the wording is it is going to aggravate, but the class of patients where they are already known to have retinopathy, we have to be cautious.
But usually, the Dr. Sati is saying you need to screen them,
We have to
which
screen.
doesn't happen in
Yeah.
every clinic.
We have to see.
So how many people have eye checkup before starting
No one.
diabetes? No one has.
Most of
But an obese, as you said, as Madam said, obese non-diabetics, I don't have to do retina.
no need.
So I should only give diabetes to those patients.
Yes.
Non-diabetic,
Non-diabetic we are using actually.
unless they are screening.
Yes.
So for hydroxychloroquine also, we usually screen for retina. It's because of the
Yes. So I think I just have one slide for all the context which we are discussing today. So it is what we always discuss as weight gain or increased weight. Basically, it's a speed of central fat accumulation which is creating all the problems. Depending on aging, sex, postmenopausal, and different ethnicity, according to that, the ectopic fat deposition changes. And then we have this abdominal circumference, which actually we know that so which will definitely correlate with the risk which we are talking. The main fat spillover happens in the liver, in the skeletal muscles, around pancreatic beta cells, and of course in the large arteries, which is vascular fat. And there is a lot of crosstalk which happens. So all these ectopic fat increases whenever the insulin sensitivity goes down. Again, depending on type of diabetes, different clusters, ethnicity, age, duration. Again, we have this high TG, low HDL, mainly which we see in type 2 diabetes in mainly our population. Again, which points out towards this abnormal adiposity. So we are talking about BMI and obesity, but more of adiposity, and we talk it more because now we have good drugs which can address these issues. This perivascular fat has an independent correlation, not only once there is a higher blood pressure, but also usually with these patients with higher salt intake because of the excess calorie intake. So it comes together as a package whenever there is a wrong diet, and that another thing, it increases the vascular risk much more in these patients. We know this epicardial fat has an independent correlation with heart failure, with also kind of a tachyarrhythmias, atrial fibrillation, and then we know this redistribution of fat happens whenever there is a weight loss measures have been taken. So along with this, there is a hyperglycemia. So all these patients face catastrophe of events at a very early life. This is what happening when there is a heart disease risk increases. We always say type 2 diabetes is CHD equivalent. Doesn't happen right at the diagnosis of type 2 diabetes, but as increasing age and duration of diabetes, every patient reaches as a CHD equivalent. The risk is different for everyone. But someone who is getting diagnosed very early in life, typically young onset type 2 diabetes, rapid increase in ASCVD, heart failure CKD risk, as more and more ectopic fat gets accumulated. Even in type 2 diabetes, once it gets there, we treat with these medicines, the risk goes down, but risk is enhanced reaches earlier to cardiovascular risk with more of a ectopic fat or this adiposity. The relationship with BMI, LDL cholesterol, heart failure is slightly interesting. There is a large data from, of course we know from Swedish National Diabetes Registry, more than lakhs of patients, so it's a good data. So if you see LDL cholesterol and its ratio with kind of a BMI or more weight, more the BMI, more the LDL cholesterol goes down, the heart failure actually doesn't go with the LDL cholesterol. But as the LDL cholesterol increases, acute myocardial infarction risk goes up, which has a direct correlation with LDL cholesterol. What happens is about with BMI, as the BMI goes up, heart failure risk goes up. Doesn't increase much of AMI. This is a registry, but now we know real world studies and registries teach us a lot, and whole precision medicine is dependent on these huge data of registries. So BMI, other than atherosclerotic risk, is definitely creating some problems with mainly heart and the kidneys. So in type 2 diabetes, main focus remained in high glucose, non-HDL cholesterol or LDL cholesterol, high blood pressure treatment, thrombotic tendency. We are doing quite good with these medicines for accelerated atherogenosis. So we treat with statins, blood pressure medicines, good A1C control, good antiplatelets, lifestyle modification, and if you see some data from US, from Europe, these rates are coming down. I'm not talking about India, but definitely. What is lacking is this surplus calories and ectopic fat, which are creating these issues of hemodynamic excess of sodium, interstitial fluid, cellular overnutrition, myocardial health issues, which again increases not only hemodynamic volume issues, mainly increasing the risk of heart failure and chronic kidney disease, mainly in a type 2 diabetic person who comes with a more insulin deficiency as well as insulin resistance, which is a very typical young onset type 2 diabetic in India who comes at around 40 age, central adiposity, some blood pressure, diagnosis with a higher A1C, comes with the reports of 9-10 A1C right at the diagnosis, and of course with this poor lifestyle. These patients are at a very high risk of chronic kidney disease. All the clusters done by Dr. Mohan, again it has a genetic predisposition done by the Dr. Yagnik's KM unit, and which shows that this is the group of patients, the clusters of patients who are extremely high risk of heart as well as the kidney, and we need to be very much aware for these different types of type 2 diabetes which present to us at diagnosis, who will be at the higher risk. And this is what GLP1 analogs address these issues, which is kind of a residual risk, I can say, which increase. We lot of talk about residual risk after statin in type 2 diabetes, multiple reasons. So non-diabetic person, the risk goes down. Non-diabetic person risk doesn't go down that much even with statins. That residual risk we were talking up till now, triglyceride, non-HDL, but maybe this adiposity is contributing to it, and we need everything which can address to that residual risk, which is happening with this, and with this of course oral semaglutide. So today that's what we are discussing about this multi-organ dysfunction with this abnormal fat, and that's what we will talk today. So in the flow, Sakli is here, Dr. Ekatpuri, he has reached. So will you please take your slides and then we have some discussion. Dr. Harshal Ekatpuri is an endocrinologist. There are people also on the online across India, so I will introduce him. He is an endocrinologist, works with Ruby Hall. So Harshal, please come. Put the slides in. Open the slides.
गरम करावा
एसी बंद करायला
कंपनी जेवण नीट कधी घेत नाही आता
क्वेश्चन मास्टर है.
स्टडी चालू आहे. हे किती वेळा झालेलं आहे?
Good evening all. Sorry for the delay.
आवाज very well.
I have a
Mic.
yeah, tooth extraction done today, so you have to bear with me a little bit. So mitigating the CV risk in patients with type 2 diabetes with oral semaglutide. Start with the prototype case. This is 45-year-old IT professional. From picture you can see that he is very obese with a BMI of 32, HbA1c of 8.5, and he is only on simple metformin. And other comorbidities are of course dyslipidemia, OSA is present, sedentary lifestyle, strong family history of diabetes, and ASCVD present. And they started on the lifestyle modification and not able to control the HbA1c and the weight, struggling with the parameters. Now, weight loss, why it is very, very important, especially in a type 2 diabetic patients, that in patients with the obesity and the weight changes over a period of years, the risk of progression towards the diabetes actually gets reduced when you lose good amount of body weight. So, with the lifestyle changes, metformin, with the help of that, if you are losing weight, the progression towards the diabetes is actually halted. So, not long back when I was doing my FD, that time the metformin was actually approved drug for the use in the pre-diabetic conditions to help achieve the weight loss and reduce the insulin resistance. And in long run, the risk reduction with the weight loss somewhere stands around 34% with a significant body weight reduction. Greater weight loss gives you greater health benefits. So the health benefit starts when you start losing as early as 2 to 5% of the body weight. So HbA1c reduction is quite apparent at those levels. And when you start losing further between 5 to 10%, again you can see there is proportionate drop in the HbA1c. For more than 10%, again significant proportionate drop in the HbA1c. And when you lose more than 15%, again there is a proportionate drop. So weight loss and the HbA1c to some extent share a correlation. It can say that once you lose a more amount of weight, you lose more amount of HbA1c reduction you can expect. Similar, that is reflected in a triglyceride levels. The triglycerides are the indirect markers of the, you can say, the inflammation present, and more amount of weight you are losing, triglycerides also comes down, the insulin resistance coming down. So, weight loss in the people with diabetes, it is actually associated with improved quality of life. With every one decrease in the BMI, and the change of utility is 0.017. So quality of life improves with a drop in the every 1 kg per meter square of a BMI. The reduction in the CV events and the risk factors. The reduction in the inflammation with the weight loss is one thing, and improvement in the endothelial dysfunction. But whether it really translates into the improvement of the blood pressure. So this improvement of the CV events. So reduction in the weight is associated with significant drop in the blood pressure also, systolic to more extent, less to the diastolic extent, but it has an impact on both. Reduction in the triglyceride level, and in general rule, as a triglyceride goes down, the HDL level goes up, and to some extent it helps stabilize the LDL level. It does not have much of an impact on the LDL levels. The weight loss or the lifestyle measures that you take hardly makes any changes in the LDL levels, but triglycerides and HDL definitely gets a good impact. 5% of our body weight loss following the diabetes diagnosis associated with 48% lower hazard ratio for CVD after 10 years. So amongst the type of ASCVD, most prevalent ASCVD is the most prevalent CVD, the atherosclerotic vascular heart disease, as you can see from this data. And in those patients, it is very important to choose the right anti-diabetic agents. So when you are using the anti-diabetic agent, it should have the advantage of glycemic control. There should be a positive impact on the body weight in terms of weight loss. Simultaneously, it should offer the CV risk reduction, pleiotropic benefits in terms of reduction of the inflammation, favorable effect on the lipid profile, and minimal risk of hypoglycemia. So when you compare GLP, SGLT, DPP and insulin, the GLP ticks all the right boxes. So it is a 100% physiological drug that you can say in the management of the type 2 diabetes. So recent ADA guidelines recommend to initiate the GLP1 receptor agonist in type 2 with established and high risk CVD as a first line agents. So similar importance should be given to the glucose management as well as the weight reduction. Person should prefer a glucose lowering agents with organ protection like GLP1 or SGLT2 inhibitors, and they should be utilized as a first line agents even over and above the metformin, and they help prevent the progression or the development of the complications, particularly the cardiorenal protection and the weight management. So GLP and SGLT, these are the two agents which have proven that they can reduce the weight, reduce the HbA1c and protect the cardiovascular outcomes. So semaglutide is one of its kind designed first very high efficacy molecule for both glucose control as well as the body weight reduction. Injectable semaglutide, which is available in the European or the American countries, 1 milligram per week usually provides the meaningful weight loss and the good glycemic control as well. So injectable semaglutide of 2.4 mg has reduced the body weight in patients with type 2 diabetes mellitus by almost 10.6%. And you can just say that the similarly oral semaglutide may have the ability to reduce the weight in the similar fashion, and the similar or superior weight loss can also be observed with the oral semaglutide therapy. So robust HbA1c and the weight reduction trials with the oral semaglutide, it has a proven result across all the pioneer trials. There are almost 12 phase 3A trials and then previous trials. Then HbA1c reduction is up to 1.5% by the oral semaglutide, but it all depends upon the baseline HbA1c. So the patients who have a higher body weight or the weight around 80 to 90 kgs, they have around 5 kg of the weight loss, median 5 kg weight loss with the oral semaglutide therapy. But if your baseline weight or the baseline HbA1c higher, you can expect much better glycemic control. So those patients having baseline HbA1c around 9%, HbA1c reduction up to 2.6% can also be observed. So there is a notable weight loss as well as the notable HbA1c reduction has been observed across the pioneer trials with the oral semaglutide therapy. When you compare it head to head with the different molecules, it is just a summary from the pioneer data. The head to head comparison with the different molecules per se against placebo and the proportion of the patients achieving the HbA1c and the weight loss are significantly higher in the semaglutide group. So when you compare it again with the liraglutide, similarly almost 3 times more patients have achieved the HbA1c target as well as the weight loss targets. So it is much more potent than even its peers like liraglutide in terms of the weight management and the glycemic control. Then the type of weight loss that you are getting with the semaglutide, particularly it is a fat loss. So even the patients with diabetes, they have a very funny questions. So when I ask them to lose weight, they say, as such, because of sugars I am losing weight, why you want me to lose weight further? So uncontrolled diabetes gives you a weight loss, which is the loss of a lean body mass. Though we don't want patient losing the lean body mass. So this study actually emphasizes that what type of body weight loss is occurring with the semaglutide therapy. So with the semaglutide therapy, there is a decrease in the total fat mass index, visceral adipocyte tissue index, and the skeletal muscle index are relatively well preserved. And when you take the ratio of skeletal muscle mass versus visceral adiposity, it has actually gone up. That means skeletal muscle mass is well preserved and the visceral adiposity is significantly reduced with the semaglutide therapy. That translates into a more physiological or the healthy weight loss, you can say. So oral semaglutide clinical trials, the results has translated into the real world setting. So the different studies carried out in the different parts of the world has replicated the similar results, especially from the solid trial in the India. You can see HbA1c reduction is around 2%, while Caucasian counterparts were stuck at 1.4, 1.6. So here, in terms of diabetes management, HbA1c reduction, we have outperformed our Caucasian peers. Similarly, the body weight loss significantly in the range of 5 kgs as a median weight loss across all the trials. So proven effectiveness across the board or different races in terms of the weight loss as well as the HbA1c reduction. So HbA1c is reduced, weight is lost, and the inflammation has got down. So that's why it has an impact on the HSCRP also. And impact on the HSCRP is 4 times higher than the empagliflozin. So overall inflammatory milieu is reduced with the semaglutide therapy. With the oral semaglutide 14 mg dose given for 52 weeks duration, the reduction in the HSCRP is almost 37 as compared to the 9 with the empagliflozin therapy. CV safety is well established in the Pioneer 6 study. Here, hazard ratio as compared to the placebo is 0.79. So reduction, number-wise, there is a reduction in the MACE as well as the reduction in the cardiovascular death. So it has achieved the non-inferiority, but it failed to achieve the superiority. But as far as the number of events are considered, they have gone down significantly. Then semaglutide, when you compare the data from the SUSTAIN 6, which is for the subcutaneous semaglutide, and Pioneer 6, which is for the oral semaglutide. So SUSTAIN 6 has proven statistical superiority as over the placebo in terms of ASCVD risk reduction. And when you analyze this data as a combination of SUSTAIN 6 as well as the Pioneer 6, you can get still a statistical superiority in terms of ASCVD risk reduction. And effects are consistent with 24% risk reduction of the all MACE events. That's why this birth of SOUL trial took place. The SOUL trial, almost 9,600 patients were enrolled, more than 50 years type 2 diabetes with HbA1c anywhere between 6.5 to 10. And primary endpoint was to demonstrate the semaglutide lowers the risk of 3-point MACE as well as the placebo. And of course the measurement of the secondary endpoints like CKD, CV events, peripheral artery disease, weight loss, glycemic control and safety. So this trial has a unique characteristic that more number of male patients were involved. 800 patients were from India, and proportion of the heart failure patients at the baseline were 23% as compared to only 10 to 15% in the previous trials. And sizable number of patients were already taking the SGLT2 inhibitor therapy. That is the most important parameter here. So they were already on certain molecules which are offering the cardiovascular protection. So baseline comorbidities, most predominantly all of them or most of them had a hypertension and the coronary artery disease, 90 and 70% respectively. Then 42% of the time had a CKD, so which is quite replicative of our clinical patient population. Most of them have hypertension, every third of them has a CKD, and almost 100 patient has a coronary artery disease. And the eGFR wise, majority of the patients having the eGFR between the 60 to 90. So these are the chunk of the patients that we see on our day-to-day practice with borderline CKD and some clinical or subclinical coronary artery disease. Out of this, the glucose lowering medication, almost all of them are 80% of them are ACE inhibitors. Most of them are the LDL lowering therapy, that is most probably statins and antiplatelet medications. Sizable half of them were on insulin, and of course many of them are already receiving the metformin. But look at here, the SGLT2 inhibitor therapy is present in almost 26.7% of the patient. Now during the course of the study, more number of patients ended up getting the SGLT2 inhibition therapy, that we'll see later. But most of the patients are on the maximally cardiovascularly protected or the maximally cardiovascularly protected therapies were already on the most of the patients. So in this, the top line results have shown that further 14% reduction in the risk of MACE, so that residual risk that we were discussing about. Then all three components of primary endpoints contributed to the MACE reduction. So CV death as well as the hospitalization for heart failure contributed. And as part of this study, almost 49% of the patient ended up getting the SGLT2 inhibitor therapy during the trial. So almost 50% of them has received the SGLT2 inhibitor therapy, and over and above that 14% reduction in the MACE is observed with the semaglutide therapy. And it was safe and fairly well tolerated profile in line with the very previous trials. So when you look at the top line results of the other CVOT trials, most of the CVOT trials, like SGLT trials, there was maximally they were on the metformin or insulin therapy. In a leader trial, liraglutide also, most of the patients were the insulin and metformin therapy. The risk reduction was 13%. But SOUL stands out in terms of majority of the patients receiving SGLT2 inhibitor and maximal cardioprotective therapy. And these patients have shown 14% reduction. So this is a quite significant residual risk reduction in terms of cardiovascular outcomes. So this risk reduction is over and above the maximal cardioprotection which is already offered to these patients. So comparative efficacy wise, when you look at the Asian people versus the Caucasians data, GLP1 usually offer greater relative and absolute MACE risk reduction in Asian patients, because we have seen from the previous slides that it predominantly leads to the reduction in the visceral fat mass, reduction in inflammation, improvement in the endothelial dysfunction. That's why Asian patients respond much better than the Caucasians to the GLP1 analog therapy. So number needed to treat is almost half that of Caucasians. So SOUL is a critical piece of the semaglutide story. Cardiovascular outcomes, the SELECT, FLOW and SOUL trial show that 20% reduction in the MACE. The kidney outcomes, FLOW and SOUL has shown 24% reduction in the composite renal outcomes. Peripheral arterial disease, 14% reduction in the MACE with the SOUL, FLOW and the STRIDE data all together combined. Then to extrapolate the data to the oral semaglutide, 14 mg semaglutide as a full dose, 14% reduction in the MACE, reduction in the blood pressure, HbA1c, waist circumference, improvement in the UACR in longer period of time, favorable lipid profile, and reduction in the inflammatory markers, that is C-reactive protein. So with that, I thank you all, and questions as well.
I request Dr. Sashi to take the camera. Open the online this. Please be here, sir.
I just want to ask questions, a few questions.
Question?
I think with the whatever top line results of the SOUL trial, do you think with the results coming in that GLP1 will be upgraded over SGLT2 in a diabetic patient? Because now SOUL we have shown on top of SGLT2 is shown. So do you think it will be a first line drug in a diabetic patient before even SGLT2?
Yeah, definitely. With the results that we are seeing, because SGLT2 inhibitors have certain limitations. The plateauing of the effect that is observed with the SGLT2 inhibitor is quite common. So many of the patients you see with the SGLT2 inhibitor therapy faltering on the glycemic response. At the end of 1 year, most of them end up regaining some amount of lost weight. That is not seen with the GLP1. And that's why the cardioprotection offered with the GLP1 is more sustainable in long run for a type 2 diabetic patients. So I definitely feel the virtue of mechanism of action of GLP1 is such that it offers the sustainable and better cardiovascular protection. That's why they are definitely better than SGLT2. Now currently the cost and the side effect profile, these are the only two constraints.
I think it's more what we talk about is pumps and pipes. So definitely for atherosclerosis, they are add-on to SGLT2 inhibitors. For atherosclerosis, definitely it's the better molecules in the early phase of the patient's life in type 2 diabetes to reduce risk.
What about the glycemic control, comparing SGLT2 versus GLP1? Suppose which one does it better?
GLP1 are definitely better. Yes. GLP1 are much more potent molecules. At the tune of 1.5 to 2%, 1.5% HbA1c reduction you can see with the SGLP1. SGLT on an average 0.8 to 1%, the median HbA1c reduction. So they are definitely potent than the SGLT2s.
Is it true that if somebody is on insulin, then the quantum of weight drop is far less as when somebody is not on insulin, when the BMI is high? So does insulin sort of decrease the efficacy of weight loss by GLP1 or SGLT2? Is there something like that?
The GLP will continue to work even in the patients who are on the basal bolus therapies. But provided that patient is on a large doses of insulin therapy, that anabolic effect will remain to some extent. So what will happen with some weight loss will be nullified by the whatever insulin patient is taken. So the fine tuning of the insulin therapy is very important in this patient, to shift on the insulin therapies which will provide very less risk of hypoglycemia, preferably very less bolus doses and more of a basal insulin therapy that can actually optimize to further propagate the weight gain. Second is when they start on GLP1, their insulin requirement comes down. So in anticipation to reduce the insulin doses is very important. Otherwise what happens, patient gets hypoglycemia and then he starts having the defensivity and actually prevents the weight loss.
Dr. Satya, see, with these kind of a GLP-1 analog and oral semaglutide, as I was saying about residual risk, that is, we do talk about lipids in general, but there's a higher risk in type 2 diabetes, and we are not ready to bring it down by good blood pressure, good A1C, good LDL cholesterol. So definitely these molecules looks like promising to help them. My question is about these unstable plaques, which you all talk a lot about in type 2 diabetic patients, and we see so many infarcts in young patients. Do you feel these unstable plaques which we treat with statins, these molecules will help them in these patients? Are there any trials?
There is no trial on stability of plaques with GLP1, but the problem with plaques is that our targets for LDL are not achieved in the majority of patients. Suppose somebody, if you see the LAI guidelines now, you know, they are very robust, they are very strict, they are far more stricter than the European guidelines. We are now coming down to less than 30, less than 50. So I think one important reason why people are diabetics still infarct is because their LDLs are controlled very loosely. I mean, today I would like to get my high risk factor LAI said it should be less than 50. Whether you use hydrostatins or use PCSK9. So that is one major issue. Now whether all these other things will help, we'll have to see. But I think they will help partially at least. But I think the most important reason is that their LDL targets are not achieved.
I agree. A lot of clinics, they are not that aggressive about LDL. I see a lot of prescriptions and with a lot of because I think there are too many things in diabetes clinic which are happening. So one, I think it's a very important take-home message, though we are using all these new molecules, but simple statins and targeting LDL below 50 is crucial.
So one more is that suppose now for us, if you want to answer that, and suppose I have a person whose BMI is say 30, that means BMI is high, and I've done an angioplasty. Should I start GLP-1 without diabetes? Is there a recommendation there to start GLP-1 without diabetes in a high-risk patient? But now whether it will help or I should or I should not start.
Who is obese?
Obese patient. Non-obese will not start.
So there are two aspects to it. If you are targeting a weight loss or you want to offer a CV protection to your patient. So cardiovascular protection is concerned, then there is no data to support the view that you can start it for the CV protection in a non-diabetic patient. Maybe we can devise a trial like that and we'll come to the conclusion. But weight loss, definitely we are using it even in a non-diabetic patients. But the recommendation would be you can just make the patient more stable. Let his underlying coronary condition, everything has to be very stable. There should not be any unstable heart failure. And And once you are assured that patient in anabolic field for weight loss purpose, there is good case you can start the
And I
GLP.
think even we are getting tirzepatide, so which is a dual agonist. So definitely their indication is for obesity, even in non-diabetic patients, and it's coming in 2-3 months. So injectable SEMA and tirzepatide are licensed for weight loss. So definitely we will use this even in non-diabetic population. Just one question to you and also to Harshit about these GLP1 analogs, because the results with right from the leader to the semaglutide, beautiful results for cardiovascular risk reduction, semaglutide, Pioneer is on the same lines. But about heart failure, the latest guidelines, or what is your opinion about it?
In routine use of GLP for heart failure, we are not using that. So if you have a specific, because we have now enough data of 4 pillars and 5 pillars now. But suppose somebody is a diabetic, obese with heart failure, I would certainly use a GLP1, which I am also using. But besides that, per se, before starting 4 or 5 pillars what we are using, I would not start this as a primary molecule. I would do for a specific substrate.
I think it's preserved ejection fraction, there's lots of data, but it's so difficult to diagnose these patients in our day-to-day practice. But yes, just one question, clinical routine, there is a lot of limitations of treadmill test, because ultimately everything is screening in type 2 diabetic patients. So we see so many patients with normal TNTs and getting events in just few months. So will you recommend CT angio to everyone?
No, I look at the high risk, the risk profile of a patient. If the risk profile is high, I would today tell the patient to CT angio. The reason being, stress test negative tell you that the stenosis is not critical. And we all know that the data is for so many years now, 2 decades ago, which showed that suboptimal critical stenosis is in fact in significant number of diabetic patients. Okay. So what a CT angio will tell me, whether it's mild, moderate, severe, soft plaque on CT angio, I would not start statins or ecosprin. But suppose somebody says moderate, stress test will be negative, thallium will be negative, but the patient is still in fact. So high risk profile, that means LPA is high, LDL is significantly high, you have a bad family history, I will go CT angio.
Microalbuminuria,
No question.
albuminuria.
So today the whole concept of medicine is the risk profile in each subset of patients. Depending on the risk profile, you tell them what is to be done. So I always feel that advising blanket investigations is a wrong thing. So we must tell people that no, now the risk profile should be studied for each subset of patients and then advise them. That is a negative, because thalliums come negative, I'm telling you. And then what happens? Thallium negative, your risk profile is not altered. Patient is badly diabetic, he is still obese, his sugars are not controlled, thallium negative, what will it do? Then you can't blame thallium on that. You are not changing the risk profile of the patient. So, the aim of a physician and a cardiologist today, I am telling you, is to be extremely aggressive in changing the risk profile. Angioplasty is the end stage of doing a plumbing job. That is not the aim of management. Management is to prevent and be extremely aggressive post procedures. But that is the role of all physicians. All physicians and cardiologists should have a protocol in their clinic. Today time has gone, I see 100 patients, I just say, that's all gone now. You must have a risk profile for each and every. Hypertension risk profile, diabetes risk profile, CID risk profile, and then treat the patients. I also want to ask you, what about adiposity? You know, people just keep on talking. So now, I don't know. Adiposity, central, this, here, there, particle fat. Now, is there a protocol for adiposity? That means, suppose a patient comes to an endocrinologist. See, I would only look at BMI. I have a simple machine, will look at BMI. So, is that enough for adiposity? Or would you actually have a protocol for adiposity and then say, okay, this patient's whatever values are X, Y, Z. So like we have for diabetes, hypertension, is there a protocol for adiposity and what are we supposed to look at? Which we should just read. I cannot do that, but you should tell me 1, 2, 3, 4.
So when you talk about the adiposity, like patient who is having 100 kg weight and suppose patient is having 70 kg weight, so BMI will obviously higher in the patient of 100 kg weight. And when you do the lab parameters, surprisingly everything comes normal. He is non-diabetic and non-insulin resistant. And 70 kg person might be having hyperinsulinemia, HbA1c around 6.2 or so. So when this adiposity is present, whether this adiposity is causing that inflammation or the insulin resistance, hypertriglyceridemia, low HDL, whether giving rise to metabolic syndrome. So when you are screening for adiposity, of course we look at the BMI, we can do the body fat analysis to see the visceral adiposity, and of course family history is of immense help. to classify the risk profile of the patient. And when we do this lab test, including the fasting sugars, insulin, HDL, triglycerides, all these things, then we can classify this patient as a high risk for progressions towards the pre-diabetes or diabetes. Then intervention starts right there. Now coming to the second patient who is 100 kg and obese and everything is normal, still he is at risk because there is no concept of metabolically healthy obesity. The adipocyte is the domesticated macrophage. When irritated enough, it will show its true colors. So these patients are usually standing on the cliff. On one fine day, they will suddenly fall down and go into the rapid development of the diabetes and the other risk factors. So if everything is normal, patient's BMI is within 23, waist-weight ratios for the metabolic syndrome cut-off limits, they are under control and there is no inflammation in the blood work, then you can be assured that this is a completely risk.
And I think a lot of discussion started when people started wondering why GLP2 inhibitors are working or GLP, how they are working. And then loads of data that how it changes the distribution of fat. And that also actually said that this abnormal fat at abnormal places is very, very important. That's what I think GLP1 analogs or semaglutide is actually focusing on.
I was out of interest in telling you this. She showed a slide of obesity and atherosclerosis. Okay, that heart failure, yes, atherosclerosis is plus minus. And I was telling you, I have done so many hundred thousands of angios now. Very fat people have normal coronaries. So people used to ask me, how is this? Because I always say, I don't know the theory. I'm just joking, but all very fat people are the happiest people. They are happy go lucky. They don't bother about their weight. They are happy. So being happy perhaps keeps their coronaries normal. And that's not answer, but I'm just telling you. But I don't know whether there is a theory behind obese people having not too bad coronary arteries, unless their other risk profiles are bad. Okay,
the answer to your one question, that obesity, what parameters one would like to have? One is BMI. The other one, sometimes previously I used to feel, do is serum insulin. Very difficult. But now, what I feel is we have to do fasting glucose. Fasting glucose is a very important parameter. Normal fasting glucose is around 82 to 88. It takes almost 10 to 15 years for this fasting glucose to go into pre-diabetic stage. The White House study which was done on nurses and the chart study was done for 15 years. It showed that the fasting sugar increased very gradually and then they became diabetic. So this pre-diabetic period, 10 to 15 years, is the period in which insulin resistance occurs, in which insulin levels go up, and during which at the end at the upper quartile you will find most of the events occur. So these are the people, so you should try to find out how much is the fasting sugar. And the fasting sugar is proportional to the beta cell function. Now, if you will see that the fasting sugar is very fallacious. Sometimes you have a late dinner, your fasting sugar will be high. So therefore you must have a average of 3 to 4 days that will tell you what is your real fasting sugar. If your fasting sugar is high, you should be careful. I think that should be the take-home message, that every physician must do a good fasting sugar. I do usually CGM. CGM will give you a very good average of fasting sugar. That means sugar from 12 midnight to 6 a.m. because the dawn phenomenon sometimes occurs, which will again vitiate the fasting sugar. So the CGM will tell you many more things. So usual practice, apply CGM, that will give you a lot of information.
Yes, point well taken. I think it's mainly abnormal fasting more important when you talk about non-diabetic population, where it definitely correlates sensitivity. Even among diabetics, there's lots of data that fasting sugar variability. Like there was a remote trial with the cardiovascular risk reduction with degludec. Beautiful data that fasting variability is associated with more higher cardiovascular risk. Now whether to treating it helps, we don't know. But fasting variability has an association with more mortality and more cardiovascular risk.
Last question.
Your comment last and we
question.
stop this here.
I am asking you, suddenly, till now only rivalries people used to come to us and we use a lot. But suddenly, liraglutide have started coming to cardiologists, which never happened for so many years. So I'm just asking you, all these, are the biosimilars, are they similar outcome-wise, weight loss-wise? So, because costs are different, so in our practice, what are we supposed to do? Because they never came to us. Now it's very common that people start coming to a cardiologist.
I think it's because of the hard work of these people, this team, because there is so much of work done by such a costly drug. Introducing such drug for Indian market, I think it was very difficult. Because this hard work, now even the liraglutide biosimilars, they are coming. We don't know about the trials, but clinically there is a weight loss, even with biosimilars.
Original liraglutide is not available. Original liraglutide
It
is
is
also
there,
available.
but I don't think no is marketing it much. But they are not marketing it for sale. But biosimilar is there is a weight loss. We can't comment about other things because there is no data. So I
Dr.
think
Sathe,
we move on.
one question.
Sir,
That with semaglutide is such a beautiful molecule which has been tried world over, and when it is available for very comparable rates, why should we go for liraglutide? When a good molecule is available, don't go for liraglutide.
That's why they are not marketing liraglutide, but we have biosimilar liraglutide, which is much cheaper, and people lose weight on that. So that's why he is asking. So thank you so much, Dr. Sathe. Thank you, Harshal. Thanks a lot. I think we move on. We will discuss few things about chronic kidney disease. I request Dr. Vedavati Purandare to lead the discussion here for kidney issues. I request Dr. Kapil Borauke to join, and I request nephrologist Dr. Suhas Monde. Dr. Kapil Borauke is physician diabetologist working in Hadapsar. Very busy practice. Thank you, Kapil, for joining for this meeting. Dr. Suhas Monde, nephrologist. Please, Suhas, join here, and Veda, please take over and we discuss about oral semaglutide and its effects on the kidney and how it is helpful of day-to-day practice.
So we are discussing about benefits of semaglutide on CKM syndrome, and from cardiovascular benefits. Now we have a lot of confidence after the SOUL study which is published. Now we move on the K part of CKM, that is kidney. And I have the experts, Dr. Kapil Borauke and Dr. Monde, who is a nephrologist in the city of Pune. And I will be asking some of the questions to both of them. Dr. Kapil, would you like to enlighten us on the FLOW study, which is excellent study, robust data which gives us confidence in prescribing oral semaglutide in CKD patients. Would you like to comment?
Basically, whenever we have to use a new drug like this GLP1 analog, rebelsis, everybody of us will be very much confident when we are backed with some data. And I think we have two very good trials which are going to help us to back up this data. Because as a clinician, as a physician, when I am practicing, my first job is not only to control sugars, but make sure that if I am talking about kidney, that how I will avoid that patient to going into progression of a kidney disease. So in this FLOW trial, what they have done, they have studied more than 3,000 patients, and they have included patients with a creatinine clearance of around less up to 25, and regardless of albuminuria, and they have included second category that is where creatinine clearance is from 50 to 75, where the albuminuria is to the tune of around 500 to 3000 milligram per gram. So what that indicates, probably they have included a group of patients which are probable of going into progression, and they have not included patients who are already on dialysis and end-stage disease. Now, with this data, when they are used both oral and injectable, the most published data is on injectable semaglutide. Over a period of 12 months to 18 months, what they have found that there was significant reduction in the progression of kidney disease. And I think this is a very good factor what we are talking about. So can we use it in moderate to severe disease? The answer is yes, good factor data with risk reduction of progression to around 24%. Not only that, what was being found that all-cause mortality was also reduced to the tune of around 15 to 18%. And third was the development of new cardiovascular event in these patients was also found to be lesser than the other group. So what that indicates that I think we have to be bold enough to use this drug, particularly to avoid progression of the disease. So in simply that less and less patients should go into him, more and more will stay to us. That is the whole idea, I think, about flow trial.
I think it's very exciting data that all the events are going down.
Yeah.
Whether heart failure events, with the kidney events, with the oral semaglutide trial. And already we are having a very exciting time to treat kidneys in our clinics also. Like we have SGLT2 inhibitors, we have finerenone, and now this GLP1 analogs and this oral semaglutide data. So definitely it's something we can do to this very high risk population. So over to you, Veda.
Dr. Suhas, we know that we would like to prevent diabetic kidney disease in our patients, and we treat the traditional risk factors like hyperglycemia, hypertension. We tell patients to avoid smoking. So what would be the pharmacotherapy which you would choose to prevent kidney disease initiation as well as progression? So what are the pillars which you would think about patients with diabetes?
So to be very honest, it will be a tailored approach. There cannot be a single rule for all of them. When the patients are being managed by a nephrologist, I assume that there is already some part of the CKD which has set in. In that scenario, we do tend to get few troubles. Like there are 4 pillars which are essential for the treatment to progress or halt the progression of CKD in diabetics. One of them is ACE inhibitors or ARBs. Second, GLP1s. Third, SGLT2, and the fourth is finerenone. So our patient's profile sometimes may not allow us to use all of them, and at that time we have to tackle or like shuffle our choices. Like if the patient is started on ACE inhibitors or ARBs and started getting hyperkalemia, obviously even though it is one of the most powerful drug or one of the most basic pillar which will decrease the progression, but in that patient it is not possible to use it. Or if I start using it and I see like sudden rise of creatinine, which is more than expected, then I need to assume that probably ARBs are not the most effective in this situation. And then at that time, I need to choose another. Second, SGLT2, if I start the patient on SGLT2 and he lands up in the urinary tract infection, which is very refractory. Mild cystitis, definitely we hold it, we treat it, and then reintroduce after some time, after with education. But suppose the patient is started getting refractory UTIs, at that time it is limitation that we cannot use it. The third one, definitely GLP1s. So even though the data shows good, probably the side effect profile of the patients in patients who are having GLP1 are not that bad. They don't get like too much of electrolyte disturbances, they don't get like sudden rise of creatinine. There will be a mild bump in the creatinine that we see and we accept it just because over a period of time the kidney function remains same. So many times when the patient asks us, the GFR goes down with this, still do you want to use it? Yes, I do want to use it because that will decrease the progression, that will give the patient few extra years to stay away from the dialysis. And the last one, finerenone, even though there are like data, robust data of that, the data is most of the time is accompanied by some other drug also, like ARBs plus finerenone, right? Alone, it is not that one of the strongest pillar to decrease the progression of it. If I am not able to use any of them, then whether I will go for that, yes, I will, because my patient need it to stay away from the dialysis. So yes, tailored approach should be the one answer to this.
I think exactly what he has said, that in all these trials, even in both these trials, all these patients were given standard of care. And standard of care for diabetic patients was using ARBs and or ACE. So all of these trials, those patients who are showing tolerance, they were put on these drugs along with GLP1.
If I may ask just a minute more, the diabetes itself is a high risk situation. So in those patients will be having efferent constricted, there will be high filtration fraction. So that's the reason we need something which will decrease the afferent pressure or decrease or constrict the afferent so that the filtration fraction will decrease temporarily. So what we are seeing here, that when the GFR is low, it actually helps to decrease the proteinuria also, filtration of the proteins also, and that is probably the mechanism where it helps to decrease the progression of the CKD. So even though one of the main pillar is ARBs, just because it is a high RAS situation and we need a RAS blockade for them. So unless until RAS blockade is there, the remaining three pillars are still weaker in terms of just kidney progression.
Thank you so much. Dr. Kapil, in clinical practice, what do you think are the obstacles in prescribing oral semaglutide? The cost is definitely there, but any other which you think that it is one of the highly listed obstacles?
If you're asking about diabetic kidney patients or only diabetic?
When we think about DKD perspective.
Okay, when I have to use this drug in the patients who are moderate CKD, important factor is these drugs are already causing a lot of GI side effects, and our diabetic patients already are having diabetic gastroparesis. Now these GLP1 are going to definitely increase this diabetic gastroparesis in CKD patients. This is one biggest challenge we have. If I have to recall my patients, the biggest obstacle what I have is GI intolerance. Second, I think will be its other effects like hypoglycemia is not that commonly seen with GLP, and I'll be not much worried for hypoglycemia. Even my GFR is to the 40s. Third comes the pill burden. Like these patients are already on so many pills with insulin, then probably that causes the risk of hypoglycemia rather than GLP1. And fourth is the cost. I think these are the only four important parameters. And whatever evidence we have evidence only for using liraglutide in dialysis or end-stage patients. Apart from that, we have to use this drug unless your eGFR is more than 25. That is one more limitation. So I have to have repeated evaluation of eGFR. And I have to be more vigilant when I'm putting these patients on. And half-life, as we already discussed, is long half-life. So once they develop side effect, probably we have to be very cautious. Because in these patients, we don't know why they have developed, whether that is uremia, whether that is electrolyte disturbances, whether that is due to severe GI side effects.
Dr. Suhas, would you use oral semaglutide in non-diabetic CKD or a person with diabetes with NDKD? And any data which shows the benefit?
So here there are two questions.
Yes.
So using GLP-1 in non-diabetics, regarding the data, the recent trial, this is the flow, but what we are seeing the data, it decreases proteinuria. It decreases the progression of the kidney disease. We know the pathophysiology. We know the drug which changes the pathophysiology. And even though we need more data, robust data in non-diabetic patients, but the pathophysiology, if it is getting altered by decreasing GFR, decreasing the oxidation stress, decreasing the inflammation or the fibrosis in the kidney, probably that is something that I would like to try. I will talk to my patient, I will say that, see, there are not maybe two options for you to decrease the progression. There is a drug which is comparatively having less side effects, but that can delay your progression of kidney disease, that can prevent you away from the dialysis for a couple of years more. Would you like to try it? And that's something which probably I will use it as a baseline, get my patient's retinopathy evaluated, make sure that the kidney parameters are monitored, proteinuria is monitored. If I am seeing that decline in the proteinuria over a period of time, that gives me more assurance saying that yes, the proteinuria is coming down. That means this patient probably will not be requiring dialysis sooner, and I can push it for a few years later. Because probably that is more important goal for me, that my patient should not reach to the dialysis. Because it's not just only dialysis. There are other complications of CKD also will be preponed, like CKD anemia, CKD NBD, mineral bone disease, fractures. They will be having sexual dysfunctions. So there are n number of things, dermatopathy. So all those micro and microvascular complications, if I am delaying by a few years, probably I will use that data.
I personally feel this oral semaglutide, all the problems with whatever it is there, GI side effects or the cost, but type 2 diabetic patients with some proteinuria, with the earlier stages, this is the indication where we should push for it, discuss with the patient. I think because maximum benefits of oral sema we are getting it in this section of patients. We can really help them for diabetic kidney disease early, maybe before finerenone, much early. Like if you go Kedigo heat map on the left hand corner, these patients will be more benefited. And so here is the indication, because it's going to reduce events, cardiac events as well in these subset of patients. So I think it's a very strong indication, and here we can definitely justify the cost, discuss with the patient, because if we can avoid patient reaching end stage kidney disease, it's a great achievement, I think, in the clinical practice.
Exactly, and there is one more point to add this. Now the longevity is more. If someone is getting diabetes by age of suppose 30, we are expecting, we normally say that the natural history of diabetes, that the kidney disease will occur by probably 40-45. So if there is something which will delay the progression of the kidney disease, or that will prevent him for few decades away from dialysis, that will be much beneficial in terms of the comorbidities point of view. Otherwise, imagine those patients will be starting getting CKD related complications at the 4th decade, and by 4.5 or 5th decade they will be on dialysis, and that will be a huge burden which will be a challenge to manage. So longevity and early diagnosis of diabetes with all these factors which are worsening are putting us under much pressure, that we should use all the possible measures available. Not only one, not only two, not only three, and every possible measure which we can delay the progression will help our patients in the maximum way.
How about if the patient is not, proteinuria is not going down, like I am using all the, and do you have some special recommendations, because we do repeat and usually there is a drastic improvement when I am SGLT2, ARBs, finerenone and oral sema. But some patients proteinuria just remains, like it doesn't go down. What does it tell us?
So there are a couple of thoughts which occur behind that. So not only diabetic control, but along with the good blood pressure control is something which will help the proteinuria to cut down. Most of the times we check our patient's blood pressure in our clinic, and that is one time of the day. Most likely the patient comes morning time, and we see all the blood pressure readings which are in the morning time which are under control. But what if by the end of the day or by afternoon, patient is having high blood pressure which is persistent? And that's something that we should find out. What is the blood pressure throughout the day for the patient? So I do tell my patient that whatever reading I am checking now in my clinic doesn't matter. What your blood pressure readings at your home, when you are comfortable, that's something which I should know to change the prescription for blood pressure. Sometimes even the patient say that no, I am stressed out now, my blood pressure is high, I should not check the blood pressure now. But that is exactly wrong. If the blood pressure is high at that time, because of stress, because of anger, because of office pressure, whatever, traffic, driving, that at that time is still affecting the kidney. Sorry, I am selfish about the kidney. So that still is affecting your kidney, and that will not help the proteinuria to get better unless until we find out what time of the day the blood pressure is high, change the antihypertensives accordingly. We need to find out whether we are on the adequate dose of RAS. If not, can we go up on the dose? As I mentioned, other pillars. And there is always a possibility that there is something like a non-diabetic kidney disease that we should not neglect. So even there are now Indian data nowadays that if you biopsy 100 diabetic patients who you assume that they are having diabetic kidney disease, almost 1/3 of them are having non-kidney disease. Non-diabetic kidney disease. The diagnosis could be IgA, the diagnosis could be MPGN, membranous, could be interstitial nephropathy, and we missed them, and those still continue to progress, and that is something that can be prevented. Remaining 2/3 are at least having diabetic kidney disease or association of diabetic kidney disease, but someone who is progressing faster, proteinuria not getting better, in that situation, I will not hesitate to do a biopsy. I'll tell that most likely this will be one investigation where we may still come home with the same diagnosis of diabetic nephropathy only. But still, if there is something else which is associated with this, suppose IgA nephropathy, now there are treatments which we can use it, which will delay the progression of the kidney disease.
So it's very important before declaring someone is non-responder, something like that for a fibrinogen, we should look into all these categories and early biopsy. Like some nephrons are not there, glomerular, and if they shrunken kidneys, patient reaches end stage. I think there is no use of doing biopsies. So, and so many times there is a mixed thing, like both are present, diabetic kidney disease as well as NTKD. So if someone nephron says biopsy, we should push our patient that they need kidney biopsy.
And second important point as a physician is that when we should be referring these patients to nephrologist is a very key factor. Because what we do in clinics, we do our estimation of creatinine, and that is a very bad marker for assessment of kidney disease. We have to look at eGFR, and that should be a standard of practice. And as you said, ambulatory blood pressure monitoring has to be there. So if we send them early, then probably they get a chance to not to wait till the creatinine is so high. Then we think about sending them to nephrologist for prevention of the disease. I think that is also one very important take home to have when we are practicing into this, because then they will help us in a better way.
Yeah, I think GFR and protein estimation it's a must. Every patient, every visit.
Thank you so much for bringing the topic of eGFR. I'm glad that I can proudly say that there was a trial which was done in Hyderabad when I was doing my nephrology, and we screened almost 1,000 patients, not patients, 1,000 healthy people who came for blood donation, and we measured their GFR. And unfortunately, it is never 125. So the normal GFR what we could calculate for our patients healthy, who thought they are healthy, could do blood donations, was around like 85 to 94.
Yes, according to the guidelines of your associations, every person has CKD. So
not every person. So that will be still CKD1 if you are having the underlying comorbidities.
But yes, GFR and at least urine albumin creatinine ratio is a must if you are treating diabetes.
Thank you so much, Dr. Suhas and Dr.
And not only ACR, if there is significant amount of like ACR is there, I would like to once in a while get a 24-hour urinary protein, because the ACR can change the point of view if the urine is too dilute or probably too
I think
concentrated.
there is a slide about semaglutide on post-kidney transplant. But we want to just comment on this, and we ask Dr. Magdum to. So one can use this, right?
Yes.
Yeah.
Oh, I have used.
Yeah. So post.
So
Is the better.
So the good part about it is that it doesn't cause any interaction with our immunosuppression medications. First of all. Second, the effect is good. Third is because we are using steroid, we are always worried about new onset diabetes in transplant patients. So we can decrease the incidence of that also. So it has helped us a lot in cases of transplant also.
Thank you so much. Thank you. I'm sorry for rushing. Thank you. Because I think we are whole Sunday morning program we are trying to fit in on Friday evening 2 hours. So, but be around. We are having a discussion and open forum. So Suhas, please wait.
Oh, okay.
Don't go away. So
No.
here. Yeah.
Yes.
So I request Dr. Mohan Magdum to start this another aspect of type 2 diabetes and how this semaglutide will help about liver fat and everything. Everyone knows Dr. Mohan Magdum. He's a senior endocrinologist. I think all endocrinologists look too fit. I think the young generation is like, so I think it's good they are practicing what they preach.
Thank you, Dr. Shailaja, for inviting me. I think this must be 5th or 6th time I'm in diabetes diagram. Thank you so much. Also thank Endocrinologist for arranging this. Before I go ahead with method, just what about what the panel was talking and flow trial was discussed. So just few points about flow. That flow was stopped prematurely because it was showing so much benefit in terms of reduction in the renal outcomes. So the committee which adjudicates interimly that how the results are going, they decided that trial should be stopped so that the people who are on placebo, they should be also benefited. So that speaks about the strength of the flow trial. And number needed to treat, one of the important aspects that about 20 patients you need to treat in a year to reduce one renal outcome. So if you compare with the statins and other to reduce the cardiovascular outcomes, it would be much better. Statins are somewhere, depending on various statins, 30, 35, like that. So that speaks about the strength of evidence. Incidentally, we have conducted this study at Pune Hospital, flow trial. So I would discuss in another domain, that is liver. We know that the metabolic disease or this metabolic syndrome, sorry, I just recently got here. So they have impact on the various body organs, and we define it as obesity associated with whatever, dysglycemia, hypertension, and central obesity is one of the important factors. When we consider central obesity, where that fat is actually accumulated in central obesity, it is not only subcutaneous, but it is a visceral fat. So here is a typical our patient, 48, diagnosed diabetes, he is obese, hypertension diagnosed 5 years, type 2 diabetes 3 years, dyslipidemia 2 years. I believe usually it is reverse. Dyslipidemia maybe 5 years ago, and then other things come. But when patient comes, we start investigating. Had some fatigue, abdominal discomfort, and incidentally found that his transaminases are elevated. So obesity and central adiposity in a patient who is diagnosed having type 2 diabetes, hypertension, dyslipidemia, so that becomes a dysmetabolic or metabolic syndrome. And here are the laboratory findings: HOTPT or ALT/AST are high, GGT is also high. So liver transaminases are high. So that talks about the something is happening to liver. Diabetes is uncontrolled, cholesterols are high, and on ultrasound there is a hepatomegaly. So this is a just 45-year-old patient, as Dr. Suhas was mentioning. The longevity is there, and we have to look at the patient's age. So I usually make out my patient aware that look, you are 30, 50 years are ahead. So same way this patient at least 40, 45 years are ahead, and so we have to take the steps appropriately, because this patient is having central obesity, and university suggests that sonography, fatty liver, raised transaminases, that is in MASLD. So what is MASLD now? So earlier we used to say NAFLD, non-alcoholic fatty liver disease. So even though it was called non-alcoholic, still stigmata related to alcohol is somewhat lingering or hovering around that terminology. Now it is called metabolic dysfunction, what is called metabolic syndrome, associated steatotic liver disease. So liver disease there in terms of fatty liver, so it becomes steatotic liver disease, and this is associated with the metabolic dysfunction, so it becomes MASLD. So steatotic liver disease, that is fatty liver, then other cardiometabolic criteria are there that we just discussed, like hypertension, dyslipidemia, and on diabetes. So if patient is having alcohol intake more than 20 men, more than 30 gram in a woman, reverse, so that would possibly classify for alcoholic liver disease. But it is not there, then in all probability patient may have this, what earlier we used to call NAFLD, now we will call it MASLD. So that alcohol stigmata or the relation that is taken off, and it becomes metabolically associated liver disease. But like NDKD, there are some other factors which also may have effect on the liver, like drug-induced liver injury, DILI, what we call, then monogenic some diseases, miscellaneous, and maybe cryptogenic SLD. So whenever we don't understand, possibly we label it as idiopathic or cryptogenic. Now, why it is important that fatty liver, as we call that sign of the why it is important? Because MASLD prevalence, the globally in liver disease patients, almost 1/3 patients are having MASLD, and MASLD and obesity, they are having very strong association, and almost it is 3 times more likely to be having MASLD compared to the normal weight people if person is obese. So a fatty liver or hepatic steatosis is there, then we have to look at the 2-3 factors, whether patient is diabetic or whether patient is obese by BMI we can say, or whether patient is non-obese. If patient is non-obese, we have to look at the risk factor like waist circumference. This is one of the important or easy factor to measure, so that we say that person is obese, because that talks about the central obesity, then blood pressure, triglycerides high, HDL low, pre-diabetes condition, HOMA-IR on higher side, HSCRP is raised, so inflammation. And if patient has in the condition, then we call it as a MSR, metabolic dysfunction associated steatotic liver disease. This condition is likely to be associated with many other comorbidities like hypertension, obesity, dyslipidemia, type 2 diabetes, CVD, CKD. So that association between these conditions we have to take in mind. Like a person is diagnosed with diabetes, we think that other factors can be there. We look for the dyslipidemia, we look for hypertension. Same way, if we index fatty liver or steatosis, we diagnose MSLD, then we think about that other factors might be also lingering, and we should actively look for that. So this occurs in conjunction with obesity and other metabolic disease like diabetes and obesity is strongly associated with the muscle, and especially if the central obesity is there, then the chances of the muscle are high, almost 50 to 90% because of visceral fat, and then hepatic fibrosis and all that can go on. So almost 50% patient, more than 50% type of diabetic patient may have this muscle. 70 to 38 patients may have this advanced fibrosis. So that's why we need to pick them early, like renal disease, we have to diagnose them early so that we can intervene. And type 2 diabetes associated with the muscle, then it is the worst outcome in these patients. Why it is important? Because cardiovascular disease 4 times more likely in these patients, all causes also 4-fold more likely in these patients, and liver related mortality also is 16 times higher in these patients. So this is a sort of color flow chart. When adipose tissue is normal, fine, when dysfunction of adipose tissue occurs, that will lead to like insulin resistance, lipolysis will increase, adiponectin levels would be lower, lectin levels were high, so on inflammatory markers, cytokine, interleukin, cytokines, so they will be high. So it is a condition which denotes inflammation and fibrosis. So that will lead to both glucotoxicity as well as lipotoxicity, and progressively the liver dysfunction will progress right from the healthy liver to NFL or steatosis or what we call fatty liver, where more than 5% hepatocytes are having fat deposition or ballooning, that will further progress to inflammation and significant ballooning, and when fibrosis starts taking place, there are stages of fibrosis 1, 2, 3, 4, and that we then call it as a cirrhosis, and end stage one may have the hepatocellular carcinoma also. So patients reaching at hepatocellular carcinoma are worse, we know. Cirrhosis again, reversibility will be much less. Fibrosis stage 1 to up to 3, there can be some reversal, but we have to then pick early, like in renal disease, at the stage of fatty liver or MASH, or earlier it was called NASH or fatty liver stage. Now, if there is weight reduction, see, very simple statement. If there is weight reduction, there would be resolution or reversal of these conditions like NASH resolution, fibrosis regression, steatosis improvement, and patients achieving the WM. So, what kind of weight reduction we are looking at? It is not very drastic, but 5%, 7%, 10% reduction has significant impact. So 10% is very, very big thing to achieve, 10% weight reduction to achieve and to maintain. And we look at just the figures, what 10% reduction in the obesity can achieve. So that is resolution of NASH, 90% fibrosis regression, fibrosis, stage 1 to up to 3 maybe, 80% steatosis improvement, that is fatty liver improvement, almost 100%. So that speaks about the benefit of weight reduction, because
weight, obesity, predominantly it is central obesity, especially in our South Asian or Indian population. So that is the visceral fat, hepatic fat, and that as it regresses, the reduction in these parameters of liver disease would be there. So these are the parameters for management of assessment and management of MESARD. There is a PIP core score which is important. It is a simple score. The age, ALT, that is the product, divided by the AST and root of the ALT. So that gives the PIP score. Platelet counts and the root of the ALT. So that gives the PIP score. So out of that, age is there, hepatic enzymes there, and platelets are there. So if PIP score is less than 1.3 versus PIP score is more than 1.3, the progression to the liver disease towards the end-stage liver disease are more likely, and PIP score more than 4.5 is strongly associated with the MAPAD, or what we used to call MASH, or what we used to call NASH. So reduction in the weight would be important, because with that the PIP score is also important. Now the various tools are there, like kidney biopsy. Again there would be resistance for liver biopsy, but liver biopsy also will help in staging, and that will help in guiding the patient to treat them aggressively. So liver biopsy, if particularly patient is progressing toward the fibrosis stage, then that would be very, very important. Suspected cirrhosis, then when the score is quite high, sonography imaging is showing the cirrhotic factor and fibrosis, then it may not be that very effective. So when we think about MSLT or any other condition, metabolic condition or disease condition, we need to treat them, and here a multidisciplinary care model would be important. Like all specialty, physician would be a mainstay, but help of maybe hepatologist if it is worsening, cardiology if patient is having cardiac problem, but any consultant, any physician should be able to treat it. So liver directed therapies, additional comorbidities and advanced fibrosis, in that case we need to refer to patient to hepatologist, but otherwise weight reduction would be mainstay of the therapy. And for weight reduction, what else than the GLP1 receptor agonist would be there to significantly reduce the weight? I think that would be the most potent molecule. Some of the therapies which are used in NFLD, NASH, they are here discussed as diagrammatically, as you can see. 5-liter. Now, curiously we feel that 5-liter causes weight gain, and how it can be treated, used for treatment of the NASH or MASH. But essentially, 5-liter mobilizes central fat or the visceral fat, hepatic fat from the center to the periphery. So patient would get weight, even the circumference, waist circumference would go up, but the central or hepatic part will go down. There is some evidence for vitamin E, maybe in combination with that. Maximum evidence is with the GLP1 receptor agonist, and most of the society, as you can see, American Association of Liver Disease, then Gastroenterologist Association, Association of Endocrinology, Heart Association, ADA, European Society, Japanese Society, German Society, they recommend use of GLP1 receptor agonist in the management of the NASH, or what we call MASH. HLD2 inhibitors are also good molecules. DAPA, EMPA, both are having evidence for that, especially EMPA is having evidence for that. But to the extent GLP1 reduces weight and this condition, that possibly won't be achieved by any other medicine. But before going to medicine, always what is important in lifestyle management, weight loss would be very important. 10%, which is very high, I would say, but that is ideal weight reduction. Even 5 to 7% weight reduction is going to give benefits to our patients. So whether it is MESARD without cirrhosis or with complex cirrhosis, we should still target the therapy with this GLP1 receptor agonist, and various GLP1 receptor agonists like semaglutide, liraglutide, dulaglutide are tried the patient may be having dyslipidemia, statin would be given, obesity, other parameters also can be considered. But as of today, in available drugs, HLT2 inhibitor, pioglitazone, and GLP1 receptor, and potency wise, maximum potency, whatever is available today, semaglutide is the maximum potency in terms of reduction in the weight. Since most of our patients, that is my patients, are diabetic, we use anti-hyperglycemic agents and we use various medicines like pioglitazone. You can see that most of the beneficial effects, reduction in amino acids, liver fat, liver fibrosis is there, but body weight goes up, NASH resolution would be there. GLP1 receptor, all positive parameters you can see, reduction in trans amino acids, liver fat would be reduced, even fibrosis is reduced early stages, stage 1, 2. With significant more than 10% weight reduction, very, very important point we should remember. Body weight also goes down and renal benefits, they are there, various trials are there, renal outcomes, heart failure outcomes, CAD outcomes, MACE outcomes, on all other parameters it is working. HLT inhibitors, some benefits are definitely there in terms of weight reduction, liver fat reduction, and so on. Insulin, metformin, DPP4 inhibitors, sort of diabetic drugs, but neutral in terms of management of muscle. So we'll just look into what is potential of semaglutide or treatment option for NASH. It reduces appetite, so satiety is improved, fullness is sensation there, hunger and all those things would be there. Then insulin secretion, glucagon secretion is balanced. Cardiovascular benefits are that I mentioned, points are improved, CHF is improved, renal outcomes are improved. Liver also, there is an outcome study sort of, cardiovascular outcome, renal outcome. So same way, liver outcome studies there that we will see. So it is a good GLP1 receptor agonist, has 90% homology with GLP, our own GLP. And approximate time of life is 1 week, reduces body weight, improves glucose metabolism, lipid levels also, and associated with CV benefit and in type 2 diabetes. So it improves metabolism, triglyceride reduces semaglutide, and that gives satiety. So acts in a way on the adipose tissue, so that the patient who are having central obesity gradually would start, along with generalized obesity, will gradually start losing the central obesity and thereby visceral fat. And as I mentioned, 5%, 7%, 10%, you can see the benefits like steatosis with 5%, that is fatty liver comes down, inflammation comes down, with 7% NASH comes down, and even 10% fibrosis also come down. So that speaks about the benefit of the semaglutide. So I will just go through one outcome sort of study, ESSENCE. It recruited patients and they had done actually liver biopsy at 72 weeks and then at 240 weeks. So very long study. And what was seen in this study, that the liver parameters were actually improving at 72 weeks. Binary biopsy studies, statin resolution were there, and improvement in liver fibrosis was also there. And at the end of study, histologic progression to cirrhosis was reduced, death from all cause including hepatic cause was reduced, liver induced ABLD score that was reduced, liver transplant requirement was reduced, and the hepatic decompensation events, they were reduced. So in a way, like cardiovascular study, outcome study, renal outcome study, this is a hepatic outcome study, and that's why it is important to think about this medicine. Though still this medicine is not officially indicated for the liver outcome or muscle. Interim results or top line results, they suggest that this would be a beneficial medicine in patients with various stages of fatty liver, including muscle, up to some fibrosis. So coming back to our patient, muscle, we consider type 2 diabetes is there, and the beneficial effects of these GLP1 receptor agonists we have seen. So important to prevent his liver condition progression, we can use GLP1 receptor agonists. so that we can give a beneficial effect or benefit to this patient in terms of his hepatic risk reduction. Thank you.
Thank you, Dr. Mandan. Please join here. So, I request Dr. Satish Patel Shetty to join for the discussion. Dr. Aditya Deshpande, Endocrinologist. Dr. Akshay Kashid, Cardiologist. We really had a wonderful discussion about some things. So now this obesity issues. Let's first, we are talking about weight loss. We are discussing this oral semaglutide. So let's first start obesity surgery. Because I think, what is your experience now? I think what we started, what I am seeing, like the scene of obesity surgery 20 years back, then 10 years back, and now it's definitely different. So, Dr. Patel Shetty, what is your, how are the patients behaving now when they come to you for obesity surgery? How are the referrals or patient come on their own? And what we have heard about Swedish study, which is the longest follow-up, though published a bit older study, but the longest follow-up, which showed decreased mortality, decreased kidney disease, decreased cancer. So multiple benefits. Still it is discussed. Like this year EASD, there is a whole session on SOS. So definitely they are too good. What is the clinical scenario?
So I would like to first thank Madam that you gave obesity surgery the first option to talk basically, not as a for the patient but to talk, because I would suggest that it's always the last option. Certainly I would say as a surgeon I would say it's the best option, but it's always the last option. The first the treatment should always be the medical treatment, the conservative treatment of diet, exercise, medications, then go towards a bit of non-invasive techniques also such as balloon therapy also, we should talk about that. And then the bariatric surgery part. So it's almost now 25 years that bariatric surgery has started in India. It started in India in 1999, and it's almost 25 years. And it has gone through its learning curve, and it has stabilized very nicely that a surgeon is doing the surgery in less than an hour. Results are very good. The complications have decreased to almost minimum to less than 0.01%, I would say. So it has become like a surgery of doing like a laparoscopic hernia surgery or laparoscopic cholecystectomy surgery. So even though if the patient is super obese, super obese, still the surgical part learning curve has decreased so much that the surgical part becomes very smooth. Patient is walking in 2 hours in the OT, I would say, because of nice anesthetic agents also, because of test fluid and everything. So the surgical part, the anesthesia part and everything, and I would say the surgical part because we optimize all these patients before they undergo for surgery. It's not that the patient comes for surgery for hernia or gallbladder and we take those patients immediately the next day. So all these patients are always optimized for surgery, and we do all laparoscopic surgery, and because of the all modern equipments, the surgery has become really a cake for all these obesity patients. And if you see the results, as we say in the SOS study, also the Swedish study, and in many other patients also, the effects are that they lose around 30 to 40% of total body weight, or you can say even 70 to 90% of the excess body weight. So when they lose that much part of excess body weight, certainly all the comorbidities also with this obesity, such as type 2 diabetes, wherein more than 93% of patients undergo diabetes remission. I would not say cure, but certainly diabetes remission. Because if they go on diabetes remission for even for around 10 to 15 years, the microvascular complications as well as the macroscopic complications decrease a lot, and the hypertension decreases, the hyperlipidemia decreases, even this NASH and the MSLE as what sir discussed, all these factors decrease a lot after undergoing obesity surgery.
See, why I started with this obesity surgery, this discussion is there are dramatic results. And people still talk about diabetes remission, but decreasing in liver problems, MASH, decreasing chronic kidney disease, decreasing mortality, and decreasing cancer, which these complications they were never taught. It was like microvascular, macrovascular. Still the textbooks talk about retinopathy, neuropathy, nephropathy, cardiovascular risk, cerebrovascular risk, peripheral artery disease. No one talks about cancer. surgery for weight loss like these GLP1 analogs. So, Aditya, your comment.
Certainly not the same results, but still.
Yeah, I won't say same, but very better results. Competent. But definitely patients don't like to go for surgery. So Aditya, your opinion about using these GLP1 analogs for weight loss and these dramatic results which we see for surgery, can we replicate them with these trials which we are seeing for weight loss drugs?
So, first of all, when we are looking at weight loss, before we had the advent of the newer generation of weight loss medications, what we were essentially looking at is a 5 to 8% weight loss, which is not going to do anything for us. Even in the slides that Sir had shown, if we are looking at improvement in MASH, if we are looking at improvement in fibrosis, we are looking at least a 10% weight loss. Same goes for other problems as well. If we look at cardiovascular outcomes, if we look at diabetes or diabetes remission per se, the ideal number is at least 10 or higher. So with the newer drugs, it has become possible, like with the current semaglutide, we can look at a ballpark figure of around 10 to 15, and even with the newer ones like tirzepatide or etatrutide or CagriSema, we are entering what is being loosely called as the bariatric surgery percentage of weight loss, which is more than 20%. And the top line results, if you look at CagriSema or etatrutide, we are looking at 23 to 24% weight loss over a sustained period of time.
Yes, so may not be to the tune of surgeries, but definitely, and the results are seen I think first 4 weeks. All the graphs are actually going down for first 4 weeks. So you can see the results and the benefits start.
Lifestyle starts improving in hospital only within 4 weeks.
Yes, perfect. So we are talking about GLP1 analogs. So first 4 weeks, there is a tremendous improvement. So Dr. Kashyap, Akshay, what is your take on these kind of weight loss with these drugs and overall cardio? Because we discussed a few aspects with Dr. Sade some time back, but your take about mainly I think heart failure.
Yeah, so we already discussed lots of points regarding the cardiac issues and improvement in the cardiac function with the introduction of GLP1 receptor agonist. Just one point I want to add, as we all of us know that diabetes tremendously contribute to the increase in morbidity, mortality, and controlling the diabetes, improving the glycemic profile definitely will improve microvascular as well as macrovascular inhibition of a progression of macrovascular complications. Now, of course, I mean, the improving the glycemic can definitely improve microvascular, but may or may not improve macrovascular complications like the avoiding the progression of cerebrovascular accidents, avoiding the progression of coronary artery diseases, and so far in the anti-diabetics, as Sir has already also shown in one of the slides, that all the anti-diabetics have got neutral effects in avoiding the progression of macrovascular complications, except GLP1 receptor agonist like semaglutide and SGLT2 inhibitor. Now, so far, of course, SGLT2 inhibitor was introduced as an anti-diabetic medication, but subsequent studies, including DAPA trials and all, the subset of a heart failure patient, they found that it definitely improved the worsening of a cardiac failure. It definitely avoids the remodeling into the cardiac muscles, and it improves the quality of life, and it avoids the 3-point MACE events. Similarly, the SOUL trial, as we discussed, it had shown that similar to the SGLT2 inhibitors, the semaglutide is showing effect. Now, only one point I want to add is that when we talk about the heart failure, there are two aspects of a heart failure. One is a systolic dysfunction, and one is a diastolic dysfunction. All of us are very much aware of the systolic dysfunction, but diastolic dysfunction or the left ventricular with piezo ejection fraction, it's something which we avoid and we neglect or we underestimate. Now, the diastolic heart failure is because there is an increase in the fibrosis of the cardiomyocytes. And it has been found that when we go for the coronary angiogram and we find that the coronary arteries are normal, but still we do not find the reason why the patient is developing the progression in the diastolic heart failure. Now, we have certain subset of patients in which we have found that uptitration of a semaglutide or upfront use of a semaglutide has definitely improving the worsening heart failure. It has definitely bringing delayed in the progression of a diastolic heart failure, and not only the major coronary arteries or the but even the micro vessels, which constitute about the 95% of the coronary channels, it definitely shows improvement. What is called is the improvement in the microvascular dysfunction. So these drugs like semaglutide and also the SGLT2 inhibitors, it's showing improvement in the avoiding microvascular dysfunction.
Yes, I think 2025 ESC guidelines,
Yes.
I have known when they were published, but the recent data they are adding level 1 evidence for HPF mainly for the quality of life and decreasing the events. Even in HPF, decreasing the events of cardiac admissions as well as the renal events. So even semaglutide is very highly recommended with good evidence for HPF mainly. Now just one question about this weight loss. So just Aditya, what is sarcopenia? Then the graph comes down with GLP1 analogs and it starts rising up. So there is a weight gain, and then they say that weight gain is a good fat. You lose muscles, any weight loss, whether it is lifestyle, whether it is GLP1, whether it is obesity solution. So can you just give us a very strong kind of advice to everyone? What is this? What are the problems with that? And how we can tackle that when we are using GLP1 analogs?
Sarcopenia is basically a decline in either muscle mass, muscle strength or muscle function. Now, before we jump into sarcopenia and why it happens, what needs to be done, the primary problem is that we have a very poor understanding of what obesity is overall. Hello?
Yeah.
So, obesity is an excess adiposity, but we measure it by BMI, where we don't know anything about the body composition per se. So, when we say the patient has to lose weight, what does the patient actually have to lose? So, in whether we look at the tirzepatide trials, whether we look at the semaglutide trials, on an average, we see that there is a 10% decrease in lean body mass, that is around 6 kg in both of these trials across various doses. Now, 1 kg loss in lean body mass roughly translates to around 13 to 25 kilocalories per day of metabolic rate lost. So, if a person is losing, let's say, around 6 kgs or 10 kgs, then the ultimate quantum of calorie requirement that is actually going to go down is around 200 to 250 calories per day, which is a lot. So, eventually, one of the reasons for weight regain might be that there is a muscle loss which has not been accounted for or which has not been compensated for. Now, one of the mechanisms as to how we can address this muscle loss in terms of assessment is not just to look at the reports or to look at the way we conventionally examine patients, but to look at muscle mass, which we can do even with a bioimpedance machine, muscle strength, which we can do with a simple hand grip test or with a simple dynamometer, and to do something as simple as a 6-minute walk test. If your patient is covering less than 300 meters with a 6-minute walk test, it is very likely that it reflects a poor lower body muscle mass and also points to a higher increased risk of mortality, even CV mortality. And in terms of treatment or prevention of this sarcopenia, resistance exercise has been shown to be the only thing that can work with semaglutide and prevent or at least attenuate the muscle loss that is going to happen.
I think there is a last month's diabetes care discusses a very good article about resistance training and all the evidence. Now more because we are using so much of these molecules, so it
So
has to
actually,
be.
I would add a point that normally what happens is when we say exercises, means there are so many Indians who say, "I'm walking kartu." So walking is our Indian national exercise. So walking is not an exercise. So there are 3 types of exercise actually. One is for cardio, wherein the patients do walking, jogging or running. These are all aerobic exercises, which should not be done more than 30 minutes, because if you do more than 30 minutes, then you get more hungry. So it should not be done more than 30 minutes. Second is most of the patients say that they do yoga. So yoga is again for flexibility more. Sometimes power yoga or doing calisthenics, that is using your own body weight, may help in bit of muscle strengthening, but not much. So yoga is more for flexibility. So as Aditya said, muscle strengthening is more important, which happens only if you do weight training. So weight training and resistance training is more important in improving the muscle mass. And especially after the age of 40, every Indian patient, Indian male, female, they should do resistance training or weight resistance exercises.
So we can get all the benefits of weight loss programs along with preserving muscle mass, even though we are using these drugs.
For much better metabolism.
So, and one more thing. Can we use, like you or not use, but more, would you like to say, these GLP-1 analogs after obesity surgery? Because even maintaining the weight after surgery is not that easy. So can we use GLP-1 analogs?
I would say it is vice versa, or rather it is not vice versa, it is both ways. Means obesity surgery, initial results are depends on what kind of surgery. I think barring maybe the bypass, most of the patients would start gaining weight after some time, as I understand.
Yes.
So in those patients, after a certain point of time, few years, if they are putting on weight, they are having metabolic parameters are getting worsening, definitely we can use. And those patients would
Actually, in the initial journey of bariatric surgery, there were surgeons who were doing most of sleeve gastrectomies. So sleeve gastrectomy is just a restrictive surgery, wherein we decrease the size of the stomach. But stomach is kind of a balloon. It is again going to increase back. It may not go back to 100%, but certainly it increases by around 20 to 30%, which causes that weight regain. And as you said, because of that weight regain, then we'll have to add some GLP-1 analogs with it, so that they have a bit of weight loss. So I always say that obesity is like a tumor, it's a chronic disease. So it should be like a tumor board, there should be an obesity board also, wherein there is collaboration between physicians and surgeons in treating these patients for their weight loss journey. It should not only surgery, no, I am a surgeon, surgery is the best thing, or someone is a physician, no, only take medicine, no. It should be a collaboration between physicians as well as surgeons for that patient in treating that obesity as a chronic disease for the weight loss journey.
So unless it's a team efforts,
Yes.
we do not get the results. Any questions? Of course, this is a discussion going on. If you want to have any comments.
These
Yes.
obesity patients will require lifelong semaglutide because all lifestyle measures have failed, then only we give them. So whether they will require lifelong semaglutide because once
Yes,
they
certainly,
stop,
sir. If you stop any GLP-1 analogs, there is a weight regain in 70 to 80% of patients in 6 to 9 months' time. So all these patients have to take GLP-1 analogs for the whole life, and that is pretty expensive. So instead of that, bariatric surgery is much cheaper option. So because if you see analyze the cost, it's around 10,000 per month, and bariatric surgery costs around 2.5 to 3 lakhs per. That's a one-time cost.
Madam, in obesity management, other than the BMI and the other indicators, which is the deciding factor showing the gravity of the situation, are the inflammatory markers like CRP and the other, which will decide the management in future?
I think any obesity with the presence of diabetes, you don't have to look anything else. We know it's the higher risk, whether the CRP is high, and then all the risk goes on adding up. If the lipid profile is bad, it is still higher risk. But obesity with diabetes, we cannot ignore that obesity. We cannot call that healthy fat or anything else. Whether it is subcutaneous, whether it is visceral, whether it is epicardial, perivascular. Once there is a diagnosis of diabetes, that every fat we need to tackle with that, and we need to treat it. And maximum benefits of these drugs, there are a lot of evidence, even with BMI below 27. And all the metabolic effects which we are discussing is with not that great weight loss with semaglutide. So what CKM, what we today discussed is mainly with even modest weight loss, because it is affecting the fat mass, the overall. And that's why every ectopic fat which goes down, the insulin sensitivity improves. And that's how the inflammation is going down. And that's why these drugs are benefiting in all the aspects, whether it is liver, whether it's kidney, or whether it is a cardiovascular risk.
So one of the slides was just showing that obesity, diabetes and muscle, then the outcomes are fourfold higher. So what you are saying that type 2 diabetes and whether definitely we need to treat them aggressively.
Yesterday I saw in news, the national channel, there is a study published for the India, that 30% of all the population have fatty liver. So this, now what I am saying, people are talking on the news channels. So at least in clinics, someone comes with a report of fatty liver, one needs to be very, very aggressive for that. And now we have drugs. It's like, we never talked about HFpEF, right? Reserve. Because we have now drugs, SGLT2 inhibitor, we are talking a lot about it. Similarly, now we have drugs about this fatty liver. So usually patients in it, so one needs to be very aggressive in treating when we have such wonderful molecules.
Definitely our approach was हे तर असतंच फॅटी लिव्हर थोडं असतं ते काय.
Madam, don't you think we are highlighting all the medications and other things, we are neglecting and sidelining the lifestyle disorders in the lifestyle management?
Not at all. Not at all.
No.
It has to be hampered.
No, nothing will work unless there is a lifestyle management, whether it is oral semaglutide, drugs. Actually, lifestyle management will be much better when we are using along with these drugs.
Because that's the thing people don't
So
want.
you can't have weight loss if you don't have lifestyle changes.
Yeah.
That's the basic crux of any weight loss journey. You cannot help that patient in that weight loss journey if the patient says कि नहीं मला diet नका सांगू, मला exercise नका सांगू. Then that patient, nobody can help that patient. No semaglutide, no surgery, not even surgery can help that patient.
But 90% of patients are like that.
So we have to assess those. That's why I said it's always a multidisciplinary team approach. You need to have a nutritionist, you need to have a psychologist to assess what is the reason for that weight gain. When you try to assess that weight gain reason and we try to see to them whether they are committed to that lifestyle change, then only we go and put them on this medication or we go ahead and do surgery on them. If they are not committed to those lifestyle changes, we should not treat them.
And out of these 90% patients who say like this, 100% will work if you pay them like lakhs of rupees on an ad for lifestyle modification. So then they will follow. So that's how to deal with the behavioral therapy. That is important. So though we have a team, unless you create something which patients are attracted, then they will follow. It's very difficult. We understand it.
Dr. Sathe said that coronaries are normal in obese people.
I don't agree.
No,
I don't
it's
agree.
not like that. What he didn't say that. Occasional obesity. See, there is lot of talk about healthy obesity, and like Sono Belwan, we talk about that, and we say that even though they are obese, their inflammation is very less. This I will say less than 1%, and once there is diabetes, you don't discuss this.
It's like what Harshal said, they are standing on the cliff.
So there is nothing like happy obesity or smiling obesity, even if the coronary vessels are normal. So what we say in the angiography is just a 5% circulation, the national highways or state highways. We do not see the micro circulation, which constitutes 95% of the circulation to the inside the heart muscle.
Diabetes
And
is
yeah, sir,
right,
diabetes,
but non-diabetic obese.
Yes, sir, even non-diabetic obese, what we say normal coronaries without obstruction, without stenosis, but they do have the moderate to severe ectasia with the sluggish coronary flow because of microvascular dysfunction. So anyway, obesity is alright. Obesity always affects.
Why infarcts are not going down in India when they are going down in states, or whether they will go down with semaglutide and ilostatins?
They are only because defective lifestyle, main crux.
Yeah, one of the very important and we think that PM Modi himself has taken the issue of obesity and he has designated 10 ambassadors, and every ambassador is supposed to pass on baton to 10 more people, and that should be chain reaction, so that awareness, when Modi ji says that awareness should be more, so it is a very well appreciated step taken by our sorry?
Not a single doctor in Brazil.
Yeah.
That is
They
good.
would do it.
That's why they will follow. Otherwise,
It has to be the general population.
Because he
Whatever the
doesn't believe in us.
no, it's not that.
It's not like that.
To change the psyche of the whole population, I think this is the best strategy. Doctors, we are always saying that. So,
one odd doctor could have been there in that day, but
Because they have got people like Guru Bhakar and other people.
They are role models. They are role models.
role models.
Role models.
Then lifestyle and obesity surgery, I think the motivation and that assessment, that is one of the parameter for before going for the
Certainly. So it's always a multidisciplinary approach towards all these obesity surgery patients, that the patient who comes for the OPD has to be assessed by a nutritionist, has to be assessed by a psychologist before they undergo bariatric surgery. It's never that, and we optimize those patients before they undergo bariatric surgery. As I said before, it's not like a hernia or gallbladder surgery that they come and the next day we can do the surgery for them. So we always optimize them, assess what is the main reason for this obesity, see whether they are committed to the lifestyle change even after surgery also, because they have to be committed and dedicated to the lifestyle change even after surgery.
How many, what is the proportion of sleeve gastrectomy and the bypass when you are operating?
So if I am operating, it's almost around 80 to 90% is bypass, 10 to 20% is sleeve. Because if you see the metabolic parameters which changes after bypass, it is much better with bypass.
I have seen creatinine is going down like anything.
Yes, with sleeve there is much of weight regain after 2 to 3 years, because the balloon, stomach is like a balloon, it is going to expand again. So bypass is, and it's a sleeve is just a restrictive surgery. What happens is patient can cheat the restrictive component, but they cannot cheat the malabsorptive component. Because even if they eat less, they can eat a bit more frequently. So they can cheat the restrictive component, but in bypass there is restrictive plus malabsorptive. Malabsorption the kernel is there, but the malabsorption they cannot cheat. So that's why the weight loss is much more, weight loss is maintained for a much more far longer period than sleeve gastrectomy.
What are these new things which we keep on hearing about, some different procedures, like cheating the intestine by putting some long thing in between, and the food is directly going from duodenum to the last end of small intestines. So are there any new procedures?
So there are 2 to 3 new procedures which are still being discussed endoscopically. They put in a barrier basically from the pylorus and they bypass the whole of the duodenum. Because major absorption of all the nutrients as well as the calories happens in duodenum and proximal jejunum.
Are these happening, these kind of
They are
procedures?
still in trials. They are still in trials. There is
They are
duodenal
not-
mucosal
Are they happening in
resurfacing.
Pune or India?
No, not in Pune.
India?
India, yes, there are clinical trials going on.
What is the
Yes, sir, please.
mechanism of diabetes
I have
reversal?
one question.
Yes, yes.
So, as Dr. Pattam Shetty sir said, lifelong continuation of the medicine oral semi-glutide will be required for the weight maintenance. So, how many patients adhere to the treatment? Means, particularly regarding the psychological
So
problems.
adherence is less than 50%.
Yes, particularly there are, is there any suicidal tendencies or like this extreme problems associated with these drugs?
There are no suicidal tendencies with GLP1 analogs. No, no.
Actually, they have been tried in terms of psychiatry. They are trying it for addictions, to get rid of addictions. There was initially 1 or 2 articles which had come out regarding suicidal tendencies. So now what is coming out is that even in terms of different addictions, it is being tried. And the other thing regarding instead of just passing the blame onto the patient, there can be mechanical issues which is causing a lack of exercise in the patient. Cultural issues like women who have not exercised their entire life, if we tell them to do resistance training at 50, it's unlikely that they are going to do it right away. They will need constant encouragement. The other thing is sleep apnea. Many of them might have sleep apnea, which is why they are tired throughout the day, which could be another reason. And regarding their food adherence, a large percentage of them, almost 60 to 80% of them, have some degree of binge eating disorder. So if we don't take care of the binge eating disorder part, then even the food adherence may not be proper.
That's why psychology is very important.
Yes, Dr. Shinde was saying something.
What is the exact mechanism of reversal of diabetes? The next day you operate.
Yes. So patient goes euglycemic immediately after the surgery the next day. So there are 2 mechanisms for diabetes reversal or diabetes remission in after bariatric surgery. First one is actually there is decrease in peripheral insulin resistance because there is weight loss, but that's a far long approach. First thing, the second day they become euglycemic because of this GLP1 theory only. Because the food goes rapidly into the ileum, there are some L cells in ileum which secrete some hormones as incretins such as GLP1 analogs which act on the pancreas to secrete more endogenous insulin. That's why there is more endogenous insulin secretion and the patient goes euglycemic the next day immediately after bariatric surgery.
What about K cells?
L cells are more important, sir, because they secrete more incretins.
K cells are there in duodenum, and the basic cause of surfacing duodenum is to prevent K cells from secreting. Actually, Dr. Narsiha Reddy, Nageshwar Reddy from Hyderabad, he is using that hyperthermia, hyperthermia and resurfacing. The basic is avoidance of K cells because they sense the
So
fat cells.
what is happening in this duodenal mucosa resurfacing is that after 1 or 2 years, these duodenal mucosa cells again reappear.
Agreed.
Those villi reappear, and again these K cells.
Because the K cells are the sensors for fatty acid.
Yes.
So the moment you take out them, diabetes reverses.
Yes.
So I think, thank you so much. And here I think we also going to have a group photograph. So Harshal, Suhas, please come on with Veda, please join on the stage. So yeah, Kapil. So he is doing the thanks on my behalf as well. So please.
So thank you for all the participation. All the faculties are extremely well explained how the extremely well presented how the mechanisms as well as the case-based as well as whatever the things has been given. So I would like to thank from the behalf of the non-notice and all that.
ऑडियन्सचे काही काढा फोटो